Hello, I'm Donald McCauley from BJGP. Today I'm talking to Professor Carolyn and Dr. David Shire. Now, David, you have a very interesting story. Perhaps you'd tell us a little bit about the background.
Okay, well, I'm a former GP from North Staffordshire, and my daughter Mary developed a severe mental illness when she was 16, which is in the late 90s. Initially, I got into complaining about Mary's care, and then the opportunity to get involved in policy development to try and avoid people getting the sort of problems that Mary had had. And that's really consumed me over the last 15 years. I stopped general practice to take that up.
David, you mentioned something when we were chatting off air that really caught my imagination, and that was not the inverse care law, but the need for particular emphasis on the care of patients like your daughter with special requirements, special needs.
Yeah, and the sort of problems that Mary was developing when she was sort of 16, 17 were the sort of things that would predict that she'd have downstream physical health problems. So she had, a poor diet, no physical activity, surrounded by cigarette smoking, and so I mean, very predictably that she would be looking at long-term health consequences, and the seeds for them were very obviously there at the age 16, 17. Now, the thing was, as a GP, I was giving lots of advice on preventative strategies for cardiovascular disease and diabetes, but to a population at 20 years older.
Carolyn, can I bring you in at this stage to talk a little bit about what we need to do generally in terms of meeting the needs of this population?
So generally, primary care is tasked with looking after the physical health of people with severe and enduring mental health problems. And they're not just monitoring and screening, but actually intervening. So thinking about a statin, talking to a person about whether they should be taking blood pressure tablets, starting diabetic medication, referring to diabetic education, and closely monitoring these people just as closely as somebody without an SMI would be monitored. So the Closing the Gap network aims to reduce that gap, particularly by focusing on improving the physical health of people with SMI.
We've changed the way we consult now in primary care as well. Does that increase the likelihood that patients with these needs might slip through the net?
It may be that this group of people are less willing to consult virtually. Having said that, there are some people with severe and enduring mental health problems who find it difficult to leave the house. And with encouragement, perhaps we could support them to use the virtual means of consulting. They wouldn't have to come to the waiting room and get stressed and anxious in the waiting room. They would be able to have a planned consultation with a clinician that they know. So I think we're trying to think as a practice of a new way of working that would be across the practice, but with this particular group of people, making the most of virtual consultations, online, email, video consultations.
David, if I could bring you in here, because that's a very interesting point that Carolyn makes, that there is a potential advantage in this new way of consulting for patients with these particular needs. What are your thoughts on that?
Yeah, I mean, I completely agree. I suppose the worry is that this population may have less access to the sort of digital media and less competence to use it than the wider population. So again, the risk is that you could actually widen the health inequality because they're not accessing a communication system that other people are. But certainly the notion of actually avoiding, long busy waits, continuity is critical for this. And I think also, in the middle of the COVID-19 crisis, I think many people would be really delighted that someone had taken the trouble to contact them. And primary care is still a very trusted source.
Today I was talking to Dr. David Shire and Professor Carolyn. Thank you very much, David and Carolyn.
Thanks, Doc.